I'll be introducing Dr. Bechard, who's with us this morning. So, Dr. Melanie Bechard is a pediatric emergency physician at the Children's Hospital of Eastern Ontario and the assistant professor at the University of Ottawa. Dr. Bechard completed her Master in Public Health degree with a concentration in health systems and policy at Johns Hopkins University. She is currently the chair of Canadian Doctors for Medicare, a nonpartisan organization of physicians advocating for an equitable, evidence-based, and sustainable healthcare system. Dr. Bechard's broad research interests include injury prevention, health economics, and equitable access to care. Thank you for joining us today.
Thanks for the intro and thanks for having me. So I have a presentation to share with you all. And special shout out to everyone who's in the western part of the country. I know it's very early for you. Now, can somebody unmute and tell me if you're seeing the regular slides or the presenter view?
The regular slide.
Perfect. All right, let's get into it. So feel free to ask questions throughout, but usually there's ample time for questions at the end too. I don't really have any relevant conflicts of interest. I am on the board and I'm the current chair of Canadian Doctors for Medicare, and I'm on an advisory board for the Medical Post. It's just a newspaper focused on physician issues in Canada. So we're going to talk a little bit about Canada's health system, both the history and how we got to be here. It's very brief though, so if you're like, it's 6 a.m. where I'm at and I don't want to hear about health history, don't worry. I think it just lays the groundwork. And especially, presumably, many of you are looking towards being healthcare advocates. I find it's really interesting to look and see how advocates of yesteryear got us to where we're at. We're going to talk about the anatomy of the healthcare system, how it's performing, and also some current issues and current events. So Canada's healthcare system, how did we get here? Going way back to 1867, this is Canada's Confederation, essentially when we became a country. There's the British North America Act. And this very clearly divided up some powers between the federal government, so our national government, and each of the provinces that were part of the Confederation at that time. And healthcare back in 1867 wasn't perceived as being a big deal. They didn't have a heck of a lot of treatments back then. So they relegated the administration of healthcare to the provinces. So a really important caveat and why that's relevant for all of you is because Canada doesn't really have one single healthcare system. It kind of has 14 healthcare systems, one for each of the provinces, of which there's 10, one for each of our 3 territories, and then the federal government does get involved in healthcare in certain populations for folks who are Indigenous and living on reserves, for folks who are in the military, for incarcerated individuals. The federal government is responsible for running that. So I think that's a really important caveat to keep in mind when we talk about Canada's healthcare system. There's a lot of similarities, but there are some slight differences depending on where you're located in the country. This also makes it a little bit difficult sometimes as a national healthcare organization when we're trying to speak with the federal government and saying, hey, we need to fix healthcare in this country. Sometimes we'll get the response, well, healthcare is a provincial responsibility and we don't have much to do with it, which really is kind of a cop-out, as they say. I don't think that should be an appropriate response, but it is unfortunately sometimes a barrier that we're met with. Now, many of you might have heard of this individual, maybe not. This is Tommy Douglas, and he was actually voted as the greatest Canadian way back in a contest in the early 2000s. He even beat out Wayne Gretzky, which you might know as a hockey player, and most Canadians love their hockey. I never got into it. I'm a bad example, but it just goes to show that Canadians even venerated the man who helped to create our healthcare system, even more than some of our greatest hockey players. So back in 1947, Saskatchewan is one of our provinces in the middle of the country. It's relatively rural, not exactly well financially resourced, but Tommy Douglas and his party put through a provincial universal public hospital insurance. So that way patients, when they're admitted to hospital, would not need to pay out of pocket. It would be government funded. And Tommy Douglas was motivated to do this because of his own experiences. He came from a humble background, and when he was a kid, he got osteomyelitis or severe bone infection in one of his legs. And his family didn't have money to pay for proper treatment. They were told that to save his life, they'd probably have to amputate his leg because that would be lower cost than actually trying to treat the osteomyelitis. However, there was an orthopedic surgeon who felt badly for him, who said, we'll treat your osteomyelitis as long as you agree to be a teaching case for my medical students. And through that, his leg was able to be saved. So that really instilled with him in his life the importance of having publicly funded insurance and accessible medical care. So the Hospital Insurances Act was so successful that it actually spread federally. So this was about 10 years later in 1957. In Canada, we passed the Hospital Insurance and Diagnostic Services Act. And this was essentially a 50-50 cost sharing between the federal and provincial governments. And the federal government basically said, okay, if you sign into this program, we'll help cover the cost for you to pay for patients in your province to be in hospital. And within 4 years, all provinces and territories joined. Now, this meant that throughout Canada, there was coverage of hospital admissions, but there is still no coverage for outpatient doctor visits, which of course is a huge gap. So much of healthcare is delivered outside of the hospital. Once again, Saskatchewan was a leader here, and in 1962, they created the Saskatchewan Medical Insurance Plan, which basically said that all physician services, either inside of a hospital or in outpatient settings like clinics, would be publicly funded. And the doctors at that time essentially freaked out. I think there's no better way to say it. They were very upset. They didn't want government getting involved in healthcare. They were very worried that by having standard government rates for services, they wouldn't be able to essentially charge what they want. Their incomes would be affected. They threatened to strike and they threatened to leave the province. And there was a province-wide strike for 23 days, during which several people experienced significant medical complications. So it was a really contentious issue at the time, and Tommy Douglas was not loved. However, the program did stay, and it eventually became so popular that once again it spread to the rest of Canada. So in 1966, we got our Medical Care Act that helped to ensure that there was coverage all across Canada for both outpatient services and inpatient services. And when this was passed federally, it was once again that 50-50 cost sharing agreement where the federal government said, hey, we're creating this program. We'll cover all physician services in and out of hospital, that the provinces need to sign up for it. And it only took 6 years for all of the provinces to sign up. And when it passed at the federal level, out of all of our members of parliament, there was 179 in favor and only 2 naysayers, which is just a level of uniformity that I don't think we've seen in 21st century politics ever. But it was kind of cool that they managed to get almost unanimous belief in this Medical Care Act. So the Medical Care Act did cover hospital physician services, but there's a few gaps. So in 1984, we passed our famous Canada Health Act. This is Monique Began, who was the Minister of Health at that time. And there was some opposition from some of the provinces because the Canada Health Act, not only did it offer to fund physician services, but it provided a few stipulations on what that funding would look like. So our Canada Health Act, which is still in effect today and really guides our current healthcare system, says that healthcare has to be publicly administered, basically meaning that it has to be run by the government. There can't be like a private corporation that's taking over running of our healthcare system. It needs to be comprehensive. So that means that there needs to be coverage for any medically necessary treatment. It needs to be universal, meaning that it applies to pretty much everyone in the country. It needs to be accessible, meaning that you're able to access it in a timely manner wherever you're at in the country. And it needs to be portable, meaning that if you're covered in one province, you should be able to access medical care without charge in another province. So I'm in Ontario right now. If I travel next door to Manitoba, I'm still able to access healthcare services in that province without needing to pay. It also importantly prohibited what we call extra billing and user fees. So right now, for every medical service, there is essentially a charge, a billing code that the government would pay the physicians. And as a physician, I cannot ask for extra money from patients. I also cannot ask patients for co-pays or things like that. It's actually prohibited by the Canada Health Act. And this is all to preserve fair, accessible use of healthcare in Canada. And it's something that's really important to many Canadians, even though many of us, I think, are not happy with our healthcare system currently. We'll get into reasons for that. I think we still have this core value that healthcare access should be based on need and not the ability to pay. So that's the history of our healthcare system. Just the angle of the sun is blinding me a little bit here, but I'll look to see if there's any questions or comments that have come up so far. Pausing, I'll open up the chat to have it available. Okay, we're good for now. Let's move on. Oh, Therese?
I don't know if this is like too broad or too far reaching, but we had a panel yesterday about like from speakers who aren't like fully in favor of state single payer. And one of the reasons is because like our states are like pretty divisive. And like for example, the ACA expansion, there are a lot of states that still haven't done it. So I was just wondering, like, if you could just like tell me a little bit more about like the political climate among different like provinces or states in Canada and what that looks like.
Yeah, great question. So because of the Canada Health Act, all of our provinces are required to provide like universal health care. The areas where we see differences between the provinces are in areas that are not currently covered. So we'll get into some of the gaps shortly, but some of the gaps would be, let's say, pharmaceutical medications, like outpatient medications, is one of the biggest gaps in our healthcare system currently. So we'll pay for people to see physicians, both inpatient and outpatient. If you're admitted to hospital, all of your medications are covered. But if you have an outpatient prescription, like if you have, strep throat and you go and pick up penicillin from the pharmacy, that is not covered. So that's an area where there's a gap, and all the provinces and territories have different approaches to how they help out patients in accessing medications. In Ontario, for example, we have a program where everyone under the age of, I believe it's 24, is able to access outpatient medications free of charge. Usually people who are on social assistance get coverage, retired people, but there's slight differences in those programs and what they look like between provinces. But really, they're much more similar than different. And I think that our system is probably a little bit more centralized than what you guys have down south of our border, at least. Good question. Okay, so let's get into the anatomy of the healthcare system. Again, not necessarily an engaging morning topic of conversation, but anatomy is really important. So if we think of something that we might be more familiar with, bone anatomy, it's important to be able to understand the structure of things in order to diagnose and fix problems. Since I know anatomy, I know that this is a regular growth plate in this child's x-ray and not a fracture. So it's really important to have some foundational way to talk about the structure of a healthcare system if you're going to be an advocate in that system. Now, there's two main elements to healthcare anatomy. Yes, only two things to memorize, a lot easier than body anatomy, thank goodness. One element of the healthcare system is financing, and the other is delivery. So financing is simply who pays for the care, and delivery is who delivers care. So far, so good, hopefully. Now you can essentially put healthcare systems onto this different grid because for both financing, it could be private or public, meaning that if you have privately financed care, that's patient out-of-pocket charges or through private insurance. If you have public financing, that comes through government sources. When we look at healthcare delivery, public delivery means that the care is delivered by public employees or government employees at government-owned and operated institutions. And private delivery essentially means delivery by any sort of standalone for-profit or nonprofit institution. So there's a lot of wide variability here. I'm going to illustrate a few different examples. Again, these are gross oversimplifications. So if you take a picture of this and like put it out online, somebody will be like, well, that's not correct because of this instance. And they're right. It's just trying to choose some broad examples to illustrate the principles, but healthcare systems are always so complex that they kind of defy easy categorization. So with that caveat in mind, hospital services in Canada, as mentioned, are publicly financed, meaning that our government pays for patients to be admitted to hospital. They typically don't need to be paying out of pocket. But a lot of our healthcare systems are actually privately delivered. So in my province of Ontario, the hospitals are by and large standalone institutions. They are not government institutions. I work in a hospital in a children's emergency department. I'm not a government employee at all, but they're private nonprofit institutions. There's a handful of private for-profit hospitals in Canada, but not very many because the way our system is structured makes it hard for people to extra charge and extra bill, and that makes it hard to run a for-profit business. Next up is an example of public financing publicly delivery is the NHS, or National Health Services in the United Kingdom. Again, in recent years, they've been outsourcing more to more private delivery of care, but this is an example where, by and large, in a lot of publicly run NHS institutions, those are government run and administered and government funded. Another example of private delivery and private financing is private insurance for a great deal of hospitals in the United States will be private standalone institutions. Of course, there's public hospitals too. There's the VA system. So I'm not saying that's all care in the United States, but just for several hospitals will be privately delivered and often privately financed. Of course, there's many folks who are covered under the Affordable Care Act who do have public financing. So it's an oversimplification, but it gives you, I think, a little bit of an idea of a way to compare and classify healthcare systems or parts of our healthcare system. Now, let's see. Oh, I don't know what happened. There we go. I was like, there is a phrase here. Here's a question, and maybe folks can like raise their hands either on Zoom or just organically with your real hand. Does Canada have universal health care? Who thinks, I'll ask yes, no, and maybe. So let's see, who thinks yes, Canada has universal health care? Maybe raise your hand. A few folks. Okay, yeah. Who thinks no, Canada does not have universal health care? I'm scrolling through to see. Okay, I don't see anyone. And who thinks maybe? Who's like, I don't know, she's asking this question for a reason. Yeah, excellent. That's like the classic medical student thing where you're like, I'm not sure of the answer, but from the context of the way they're asking the question, something is up. Okay, so the question is, it's kind of a trick question, of course, but the answer is no. But then, does any country in the world have truly universal health care? Probably no. And it all depends on our definition of universality, which I think is really important. This is a way to measure universality. It's a little intimidating. Don't worry, we'll look one part at a time. This is from the World Health Organization, and this cube essentially creates like a 3D structure of different dimensions to discuss the degree of universality of a healthcare system or healthcare program. So this is a really helpful way to conceive of different healthcare programs. Number one is the degree of financial protection. What do people have to pay out of pocket? So you could have a healthcare program where the government covers 50% of costs and patients have to pay 50% of costs. So that has some financial protection. You can have a program where the patients don't have to pay anything out of pocket. So in Canada, we tend to have pretty good financial protection. If a service is covered, it's usually covered 100%. And in fact, we made it illegal to charge patients extra out of pocket. So there's pretty good financial protection for our covered services. But this brings us to question number two. Which services are actually covered? So there's a financial protection and then there's a comprehensiveness. As I mentioned before, one of our key tenets of universal healthcare in Canada and our Canada Health Act is that it has to be comprehensive, meaning that any medically necessary service should be covered. So we do tend to have fairly good coverage. There are, of course, a few big gaps. For example, outpatient mental health care can be a gap. We'll cover services to see psychiatrists, but we won't necessarily publicly cover, let's say, outpatient psychologists or social workers. So that's a gap. We've talked about outpatient medications. There's some hospital services that are not covered, but those are pretty rare. Things like cosmetic surgeries are typically not publicly covered. You know, if you want to get something done for cosmetic purposes, our country has deemed it typically not medically necessary, unless, of course, there's a few different examples, like for people who are getting gender affirming surgery or people who are getting reconstructive surgery, for example. Next up is a population who is covered. So we talked about how much coverage you get, what services are covered, but then who actually is able to access the coverage. And again, this is pretty universal in Canada. If you are a legal citizen, you essentially have access to healthcare coverage while you're here within the country. And that allows us to figure out how close a healthcare system is to coverage. Now, Canada is a fairly high income country. We know a lot of low middle income countries need to be a bit more strict with the resource use, unfortunately. So you might see in some countries, they're only able to cover the really high value aspects of care. So maybe they'll cover just maternal care and antenatal care, for example, or care for children under the age of 5 and maternal care, and everyone else is on their own. So there's no healthcare system in the world that doesn't have resource limitations. There's no country in the world that has infinite money. We all have to make some trade-offs and make some decisions about coverage, and which is why no healthcare system is truly universal, although Canada does come very close. So honestly, any answer you gave would have been correct. Anyone have questions about this cube of universality or anything else? Okay, we'll move on to service coverage. So let's talk a little bit more about what is actually covered in Canada. So I've discussed this a few different times, but I've got the services on the left, the financial coverage on top. When we look at outpatient care, visiting a family physician for a sore throat, being referred to a specialist for chronic back pain, the cost to the patient is $0. This is publicly funded. Same thing for any sort of hospital care. Maybe you're visiting the ED after a motor vehicle collision or being admitted for appendectomy. Thankfully, no cost to the patients. Where we get into a little bit more murky waters is outpatient prescription medications. As I've mentioned a few times, we don't have pharmacare in Canada, and this is what varies by province and territory. I've listed a few examples here in my home province of Ontario of people who are able to get coverage of outpatient medications. This has been a big area of advocacy for many of us who work in healthcare in Canada, and especially for us at Canadian Doctors for Medicare. And we're very happy to report that although we don't yet have a full pharmacare program, through a number of years, our organization and many, many others have managed to convince the federal government to offer free medications, essentially publicly funded medications for diabetes and also contraceptives. So this is a federal program where essentially they provide federal funding for provinces to cover these medications for the people living within their provinces, but the provinces have to sign up and agree. And I think right now we've had 4 or 5 provinces sign up. There's a few more who are negotiating. So I'm hopeful that in the next few years, people will actually be able to access these medications free of charge. I think the government was nervous about implementing a full stage pharmacare program that covers absolutely every medication or every medically necessary medication. So they took an approach where they're very restricted. And I think through various consultations decided that diabetes medications and devices, as well as contraceptives, would be some high impact areas to start with. Of course, we're going to keep advocating that there's broader coverage because, it's hard to justify why is diabetes medication covered, but not medication for asthma or COPD. It creates some really odd disparities between patients that we see. So we're hoping that this is a start, but that there's a lot more work to do. Next up, I have a big update, even compared to last year's presentation. So dental care, outpatient dental services, dentistry didn't used to be covered in Canada. A lot of people would pay out of pocket, or they'd have to purchase private dental insurance, or maybe access private dental insurance through their work. But in the last few years, we've had the Canadian Dental Care Plan. Now, this is what we call a Fill the Gaps program, meaning that you can only access it, as you can see here from these requirements, if you don't already have access to dental insurance. So through my work, I've paid for a private insurance plan to cover outpatient medications and outpatient dental services. So I'm not eligible because I've already purchased a private insurance plan. You also need to have an income less than $90,000. And of course, you need to be a Canadian resident and be able to prove your income by having filed tax returns in the prior year. But this is a great way to catch some of the people who fall through the cracks. There's problems with the administration of Fill the Gaps programs as opposed to truly universal programs that just automatically apply to everyone. But this has been, I think, a big relief for many people in Canada. Next up, now that we talked about services, let's talk about that degree of financial protection. So again, we have a fairly complete financial protection in Canada. Oh, sorry, Ariana, did you want to ask a question?
Hi, yeah, I was just wondering, maybe I misunderstood your point about the Canadian dental care, but why are there still like private dental insurers if it's now like covered, essentially?
Excellent question. So the private dental insurance has been here for years, so that kind of predates the public coverage. And the public coverage is actually pretty good. It's pretty broad, but sometimes the private dental insurance will be able to say, oh, well, we cover a little bit more than the private program. And a lot of us, I think, still have our private dental insurance just because we purchase insurance packages to cover our outpatient prescription medications, and dental insurance was part of that. I do wonder if some people will start canceling their private insurance now that we have the Canada Dental program. It is a little bit annoying though. You have to apply for it, so it's not necessarily a guarantee. I mean, if you meet the requirements, absolutely you should be eligible for it. But I think a lot of people are nervous. So if I cancel my private insurance and then something goes wrong with my application for the government insurance, I might be out of luck. There is also a little bit of contention at first where some dentists were not happy with the Canada Dental plan, saying that it doesn't provide adequate fees for the services and that private insurance would pay them more. So there's some dental offices that would say, look, I live in like a very expensive city with a lot of costs. I'm not going to be able to accept the Canada Dental plan, but everyone would still pretty much accept the private insurance. So there's some thoughts that maybe there could be access difficulties there. I think that it's still so new. It's only come out in the past 2 years or so, that we're still kind of learning whether or not this has actually come to pass. Most of the dentists I've spoken to do cover or do take the Canada Dental plan, but I think there's still some growing pains, and many of us are still hanging on to the private insurance for dentistry for that reason for now. Great question. Mhm. Okay, so again, financial protection in Canada is generally pretty solid. As long as you're covered, you don't have to pay anything for your healthcare. There's no co-pays, there's no deductibles or anything like that. It is illegal to have it. That being said, there are some gaps. So this was a study done back in 2014, and they essentially surveyed about 500 people who had declared bankruptcy from 2008 to 2010. So this is a while ago. And they had a really low response rate. I think it was only about 10%. So it's not a great study. Out of those who responded, though, 22% said that medical bills contributed to them declaring bankruptcy, and only 7% of them had medical costs higher than 5,000 Canadian dollars, meaning that these were folks who were unfortunately already pretty precarious financially. If $5,000 is the difference between being able to stay afloat versus bankruptcy, you're already in quite a difficult situation. So it's not common that people declare bankruptcy for medical purposes in Canada. For those who did say it contributed to their bankruptcy, though, they said it was mostly a cost for outpatient medications and also dental care costs. And as you've seen, we're slowly working towards covering those gaps. So this isn't a perfect study, but I wanted to include it just to show that, yes, it is possible to go into bankruptcy or to be severely financially affected due to healthcare costs in Canada. But thankfully, it's still not common. And again, this is done back in 2014, so there's been a lot of changes to our system since then. Zachary?
This is a question. I know cancer drugs are typically a large cost for a lot of people, and in the United States, under our Medicare program, I think they technically count as like outpatient medications. How are they covered under Canadian? Are they, since their infusion is an inpatient, or?
Yeah, that's an excellent question. So the answer is it depends. And this is one of those areas where it can really vary between provinces and territories. So in some provinces or territories, your outpatient cancer medications, your chemotherapy might be entirely publicly covered. In others, you might have to pay out of pocket either the entirety of it or some portion. So it is a huge area of disparity right now. It is an area that they're working on closing the gaps. I'm pretty sure that for like the infusions that occur in hospital, even if you're going in as an outpatient, I think those are covered. But a lot of people will still take like outpatient pills as part of their chemotherapy regime, and those may or may not be covered. And those can be expensive too. All right, let's talk about population coverage in Canada. So as mentioned, it's fairly complete. Again, if you are a legal citizen of the country, you are entitled to all the benefits of the full Medicare coverage plan. So it's really hard because a lot of the people who are not covered are undocumented, and that's of course a really difficult population to study. It's really hard to estimate how many people within Canada are undocumented. There is a study that was done back in 2012, so again, quite a while ago now, that did try to estimate the number of people in Canada that were uninsured. And their best guess was that about 1.4% of people were uninsured, either because they were here undocumented or essentially illegally, although I know some people don't like to use that term. Maybe they had applied for refugee status and they were denied and are trying to avoid deportation. There is also a 3-month waiting period. So when you come to Canada, if you're here immigrating or claiming refugee status, even if it's accepted, there's a 3-month waiting period before that health coverage kicks in. So that can sometimes leave people in a little bit of a precarious position. So it's not unheard of course, to be uninsured in Canada, but thankfully fairly rare. And knock on wood, throughout my medical career, I don't think I've actually encountered anyone who didn't have access to health insurance. There's maybe once or twice where I had individuals who were traveling from abroad, but I think that they had actual travel insurance with them. So it is a bit of a pain to go through to get your travel insurance coverage, but it is a big luxury, I think, for physicians in Canada. I don't need to worry about how I'm going to get paid. I don't need to chase down patients for money. I have never in my life had to call a private insurance company advocating for a patient to get coverage for a treatment. I'm able to just deliver that treatment. And hearing from and speaking with some of my colleagues in the States, that is a huge burden for many people. And I'm very glad that despite all the challenges of our system, that is not a burden that I've had to deal with. Okay, so let's talk a little bit about Canada's health system performance. Now, some of these stats are a bit out of date. They're all pre-pandemic, but I think they more or less kind of apply. When we look at healthcare costs per capita, Canada still spends a lot. We're still behind the United States in terms of the cost of our healthcare system. But you can see we're kind of on par with some of the other countries like France, Denmark, and Australia. When it comes to how much of our spending is from public or government sources, though, I think it does surprise people that we have a relatively high percentage of healthcare spending that is from private sources or from out-of-pocket payments. And that is largely due to the uncovered areas of our healthcare system, like those outpatient pharmaceuticals, or through dental care, outpatient mental health care, vision care like optometry, etc. And we do spend a lot on pharmaceuticals. Canada overspends on medications. Our medication costs tend to be extremely high compared to many other countries in the world. Part of this is because we have our different provinces and territories that are all individually negotiating drug prices. There's been more of a move in recent years to try and purchase medications on behalf of the whole country, so bulk purchasing and driving those medication costs down. So we are improving. I think we were the third highest cost of medications in the world, and now I think we've dropped to 4th or 5th. So we're making slow progress there. But that's yet another reason why we want to roll out our universal pharmacare program. Part of the reason why the cost in our system, I do feel like physicians have to take some accountability. In general, we're fairly well paid in Canada when it comes to physicians. We do have an agency called the Canadian Agency for Drugs and Technology in Health, or CADTH, that essentially assesses new medications, new medical devices to see not only are they efficacious, but are they cost effective? Meaning, do they provide efficacy, but do they do more than other drugs and devices that are on the market? So I think a lot of systems that have a high degree of public funding have agencies like this to make sure that we're not just funding any shiny new object, that we're being smart with how we spend our money. So I'm glad that we have that kind of check and balance for what we do publicly cover. Now, whenever we talk about Canada's healthcare system, a lot of people are like, oh, it's great, but those wait times will kill you. So let's look into some of the data to see whether or not that's actually true and where we're at. So these data are getting pretty old, but the share of people who sometimes, rarely, or never get an answer from their regular doctor's office on the same day, and in Canada tops the list, meaning that people have a really hard time getting in touch with their regular doctor's office. In recent years, I think we've seen so many people lose access to family medicine that a lot of us are just grateful to have a regular doctor at all, let alone being able to get in touch with them on the same day. So this is pretty bad. We look at the number of people waiting 1 month or more for a specialist appointment. Again, Canada is pretty high up on that list. When we look at certain areas, though, from referral to treatment, for cataract surgery, Canada is actually a little bit below that OECD average. When we look at hip replacement, Canada is kind of just at that OECD average. And for knee replacement, again, we're a little bit below that OECD average. So I think some of the biggest gaps in our system right now in Canada in this post-pandemic world do have to do with access to primary care and longitudinal primary care. A lot of our family physicians, I think, are not well paid. It's a very difficult job. They don't have a lot of supports or multidisciplinary teams. So there's initiatives to try and fix that. But we have a major health human resource crisis in family medicine, which is a big issue because in Canada, you can't self-refer to most specialists. You need a family doctor referral. So if people don't have a family doctor, they can't even get in to see their specialist. So a lot of folks will come and see us in the emergency department. So I think that's our biggest issue right now. Once you actually get your family physician access and get your referral, there is a wait, but the wait is pretty much on par with what we see for many other countries. And as I mentioned before, every country has resource limitations, and we kind of need to decide how to prioritize those resources. And in Canada, we actually do a really good job for quite urgent surgeries. So not to, downplay the effects and the pain and the debilitation that can come from waiting for a hip replacement, but for things that tend to be more deadly, like waiting for a coronary artery bypass, our median wait times are well below that OECD average. Waiting for a prostatectomy for prostate cancer, we're also quite well below that OECD average. So I think when it comes to the more urgent things, there's less waiting. And this matches what I see in the emergency department. Right now, if you come into our emergency department for, a minor injury, maybe there's been like a pain in your arm for weeks at a time, we will see you, and it might be hours and hours till we see you. But if you come in with difficulty breathing, with an anaphylactic reaction, you are seen within seconds to minutes of entering those doors still. Now, another important aspect of our wait times is equity. And this was a study done in Toronto for surgical referrals. And they found that wait times are not influenced by socioeconomic status. So we've got the year on the x-axis, the mean wait time on the y-axis, and then all these different colors represent the least deprived, so essentially the richer populations. And then the orange is the most deprived, or quote unquote, the poorer socioeconomic populations. And you can see that they're fairly equal. If anything, those who have less resources tend to even have shorter waiting times. I think some of that is likely because of the severity of the problems that are presenting, but I don't know if this study controlled for that. Now, the other thing too about our system is that it does tend to be financially efficient to have a single payer system. When you don't have to argue with insurance companies and budget for all of that infrastructure, you can spend a little bit more efficiently on your healthcare system. We don't need to go and assess eligibility for our government-funded healthcare programs. You're essentially just assumed to be eligible if you're a citizen of the country. Again, there are some differences, like I talked about with that Fill the Gaps dental care program. And again, our healthcare system is not from perfect, but if we consider the pandemic as a bit of a test of a healthcare system, I was actually pleasantly surprised to see some of these data that Canada had a really high percentage of the population fully vaccinated against COVID. And that unfortunately, when it came to COVID-19 deaths and mortality, Canada was relatively low near the bottom compared to many of these other high-income countries. So again, our system's not perfect. I work in it. There's definitely major access issues. We see major issues, especially for people who are more rural or remote, Indigenous folks, especially in our very wide geographic distribution of Canada. We have a lot of problems, I think, with delivering healthcare everywhere. That being said, when we compare it to other countries, I think overall our system does a pretty good job in the areas where we want to improve it. Is through improving access through those big gaps that we have, like the outpatient medications. So we have near universal population coverage. It's fairly equitable, fairly simple. That keeps our administrative costs low. And then there's also something called adverse selection. So I don't know if folks have covered this principle before, but in healthcare systems, If you have a private insurance and then a public insurance, usually the people that can purchase a private insurance have more money. They also tend to be working, so that ends up being a bit of a healthier population. So the private insurance usually has to pay less because just to get in the door and to be able to afford that private insurance or access it through work, you need to have some degree of health, meaning that folks who rely on the public system have a higher risk of maybe having less health and having more expensive healthcare needs. So that means that you can get private insurance companies which are collecting money, spending some, but maybe not a lot or enough. And meanwhile, the public system is really overburdened and strained with folks who have higher needs. So by putting everyone in the same pot, it does kind of average out that essential healthcare risk and healthcare expenditure risk. And I just wanted to briefly mention again that Tommy Douglas, who was instrumental in being one of the many leaders who rolled out universal healthcare in Canada, was declared the greatest Canadian back in the 2004 contest. And again, he even beat Wayne Gretzky. And there's a poll done, I don't think we've polled recently, but one of the more recent ones was back in 2012, and 94% of Canadians did consider Medicare a source of pride. So I'd be very curious in the post-pandemic world how people feel. This is a view of my little office. This is one of our resuscitation rooms in the emergency department. And again, just from my personal experience, I do have patients waiting upwards sometimes of 12 hours to see me in the emergency department. Again, usually for more minor conditions or more chronic complaints, but we're still able to see folks in this resuscitation room within minutes. And I feel very grateful that I've never had to deny a child or family care for financial reasons. And I think that is a bit of a privilege in the system. So before we move on, I was going to briefly mention a few current issues in Canada's healthcare system, a few current movements. Any questions or comments or reactions? Okay, we'll power through. So I've spoken about pharmacare a great deal. In general, depending on the study, anywhere from 1 in 10 to even up to 1 in 5 Canadians have difficulty affording their medications that they're prescribed. Various analyses have actually shown that pharmacare would save money in terms of reducing spending on pharmaceuticals and would actually prevent emergency department visits and hospitalizations, which is very important in a publicly funded system. That old saying, an ounce of prevention is worth a pound of cure, really makes sense. And it is so silly to think that we've essentially set up a system where we won't necessarily pay for the medications to keep you healthy and to keep you out of the emergency department and out of the hospital. But once you have complications and are sick enough to go to the emerge or to be in the hospital, then we'll pay. It really doesn't make any sense. And I think that more and more people are recognizing that. So again, we've made some movement in oral contraceptives and diabetes and medications and devices, which is huge. But we, I think, really are lagging behind many other high-income nations in terms of not having any sort of universal pharmacare program, especially when we already have a fairly universal healthcare system. I did want to mention, of course, not everyone in Canada is super happy with our Medicare system. And a few years ago, there was actually a major trial out in British Columbia, in the west part of our country, looking at the Cambie Surgeries Corporation. So this was essentially a group of physicians who felt as though it wasn't fair that people were waiting on wait lists when they could pay to afford faster care, and that essentially the provisions against extra billing and duplicative private insurance were actually infringing upon the rights of the people who had money to pay for faster care. So this was a long 4-year court case that was heard at the BC Supreme Court. And essentially, the justice, after considering 4 years of various evidence and hearing from various people, both patients and healthcare providers, essentially decided that creating a two-tiered system, so introducing duplicative private insurance, would likely increase that demand for public care, reduce the capacity of the system, and essentially create a system of preferential healthcare where access is contingent on a person's ability to pay. So even when our Medicare system was trialed in a neutral court, They essentially decided that the weight of the evidence is on the side of still maintaining our universal publicly funded system. This court decision was actually appealed by the plaintiffs who brought it to the BC Court of Appeal. The BC Court of Appeal upheld that initial decision. And then they tried to appeal it all the way to the Supreme Court of Canada, but the Supreme Court of Canada said, you don't really have a case. We agree with what happened at the BC courts. So that was really interesting to see because that could have possibly fundamentally changed our healthcare system. And I think was a good bit of validation that yes, our system, although it's far from perfect, probably has more strengths and weaknesses, and that the things that would make it better would not involve asking patients to pay for their care. So that's most of the content that I wanted to share with you. I do have various references which I can skim through. If anybody wants this presentation, let me know and I can send it out to Marvin to pass on to you. But at this point in time, I'll pause and see if there's any questions or comments. We have lots of time.
I'll start us out, and first I want to say thank you. Being so, neighbors with Canada, I think a lot of us have heard misconceptions or lots of critical things about why we can't have a Canadian health system. So this presentation will be very helpful in us advocating for the Canadian health system and why that might be reasonable for the United States to move towards. And I wanted to touch on the process of administrative costs for physicians. I know you said that you bill directly for your own services that you provide. I know in the United States, we have a lot of like auxiliary staff and whole teams of people dedicated to administrative costs. I was just wondering what it's like for you. Do you just have a portal with the government and you just say, today I did these things, or do you have staff as well?
Yeah, excellent question. Most hospitals or physician groups will still have billing staff to help out with some of these things. And even at CHEO, it's the hospital I work at, there is staff who does look over our billings to sometimes audit and make sure we're billing correctly because we tend to be pretty bad at billing. Now, part of that is because in my personal hospital environment, we have an alternate funding plan where I just get a salary. So I could see 5 patients a day, I could see 35 patients a day, and I would make the same amount of money. This is because, there's different models and not every hospital is paid the same way. There's different pros and cons to each. Having a fee-for-service model where physicians essentially make what they bill can be good because it incentivizes people to maybe work a little bit faster. It incentivizes people to take more nights and weekends because you do get extra pay for those unsociable hours. But then it could also disincentivize people from maybe taking more complex cases. So if I know I can make $200 by fixing a child's fracture, and that's going to take me, maybe 10 minutes, versus seeing that poor kid who's had 3 years of abdominal pain, where I'm going to spend like 45 minutes, maybe not bring them a great deal of relief or come to a great resolution and get paid only $60 for that. It's really hard to ignore that if you're in a fee-for-service environment. So we have the salaried model, so that way, we're pretty much happy. I don't think there's as much quote unquote cherry picking as some people say. I think some other hospitals have a blended model where you get a base salary and then a percentage of your billings to try and get the best of both worlds. But for myself, again, I get paid pretty much the same amount every month. I have to do a certain number of shifts. Those shifts are pre-selected and set out for me. I do have to bill though, just so that way the hospital can say to the government, hey, here's the amount of work we've done. Please give us this amount of money so that we can pay our physicians these salaries. And we're on the Epic system. I think many hospitals have that electronic medical record system. So after I see a patient, I just click a button essentially saying, how much I did for them and then what time of day, if it was a weekend or holiday. And that's all I have to do in terms of billing. I don't need to do anything else. Most physicians, if you're working in like an outpatient setting, I have done some of this work before where you essentially have a billing app and you just kind of like put in the patient's health card information, click and say what you did, and then you get paid afterwards. So if you're a big physician group or a high billing group, some of them will hire billing experts to like look over their billings and maximize them or to help with the billings. But a lot of physicians in Canada will just do it themselves because it typically is not a huge burden. Great question. And thanks for the nice comments. Anything else? There's really and truly, I will not judge. You can ask really anything. You can be like, what is a Canada? That's fine. I'm not coming for judgment. Ariana.
Hi, thank you again for the presentation. It was very informative. I guess I'm just wondering about the costs of drugs that people are actually paying because I know without my insurance, I would be scared to pay for drugs out of pocket. So like, can you maybe give like a range of like what people are paying for like, I don't know, their common like I don't know, common like strep throat medicine versus like if someone needs to take like a blood thinner or something because they recently had a stroke, like how like what is the range there?
Yeah, good question. Oh my gosh, it's so variable. Usually for like generic medications and a lot of our antibiotics like strep throat, amoxicillin, I think is usually pretty cheap. I couldn't put a number on it, but my best guess would be below 20 Canadian dollars. I can say for medications that I take, so obviously just have more experience with that and paying for that. I have chronic migraines, so I have a number of different migraine medications, many of which are like brand name and not generic yet. And I had a change in insurance providers recently, so I went to the pharmacy to go pick up my medications. And medications that I would usually fill this prescription every month or so were $300 with no insurance, which would be hugely cost prohibitive to like the vast majority of people. Thankfully, I spoke with my pharmacy and I'm like, oh, I think there's just a change in provider, and I gave them the new info. And then that cost went down to $30. So still a burden, still a fee, but something that's much more manageable, at least for me. But yeah, it can add up really quickly, but it's so variable. It varies depending on the medication, the brand of the medication, even where you are in the country. And I think this is something that's very similar in the United States. There is not a lot of transparency in medication prices. So if it sounds like my answers are vague, part of that is because it's very hard to find out how much medications actually cost. And I think there's some thoughts from some that this is kind of purposefully obfuscated by the pharmaceutical industry to try and justify higher medication prices.
Thank you. And can I ask a follow-up question to that,
Sure.
which might be a dumb question, but you were mentioning like your private insurance, and we talked a little bit about private insurance with like dental care, but I'm assuming with private insurance in Canada, like there is in the US, you would have to pay like a deductible, but like how like is does it work differently in Canada?
Oh, no, good question. It varies so much on the private insurance company and the insurance plan you have. I think for me, I do have a deductible, um, where if I reach it, I pay like a lower portion, but I don't think the cost completely goes away. But yeah, it's completely there's so many different private insurance packages that it's really variable. Mhm. Therese?
Hi, I was wondering what physician lifestyle is like in Canada, and also if Canada's facing a physician shortage, and also if so, like what strategies is Canada doing to increase that number?
Oh, excellent question. Okay. Physician lifestyle, I would say, is so variable, um, depending so much on your specialty and who you are. I'd say my lifestyle is pretty good. I mean, I work in an emergency department, so there is shift work, which has major social implications, lifelong health implications as well. Is very nice though, because when I travel, I'm never jet lagged because I'm constantly jet lagged from the shift work. So that part is nice. But for most pediatric emergency medicine, and this is true both in Canada and the United States, it's quite similar. A full-time job is usually 12 shifts a month. Now, that's kind of your base. If you take vacation, you often still have to do those 12 shifts, so they get compressed. If you call in sick, you need to like pay back that shift. So on paper, it sounds really chill, but it can end up getting to be pretty busy. I have a role in educating our medical students, sorry, our residents about research. So I get to do one less shift a month. And then just very recently, I got a little bit of more time for my research. So now I do about 10 shifts a month on average, which is great. I find that I'm able to balance like the academic and clinical responsibilities. I also I work part-time as an indoor cycle instructor, as a spin instructor. That's something that I just picked up because I like to work out a little bit every day and figured might as well pay to or get paid to work out a little. So I find I have a good lifestyle, and that's probably true for Most of our colleagues now, there's some specialties where it's really rough. Obviously, trauma surgery, I don't think that's an easy residency and it's not an easy staff lifestyle. Again, my friends in family medicine, I think, are really struggling because of the lack of support and the way it's compensated. They're really compensated to see the patient, but oftentimes there's so much more administrative burden in terms of sending off referrals and filling out forms. And a lot of that work is uncompensated. Many of my friends will like work a full day clinic, like 8 a.m. to 5 p.m., and then come home and have like 4 hours of documentation administrative work to do, which can be a really rough lifestyle. And they're often not compensated very appropriately for it. I will say, and this is a very similar issue in the United States, that there's huge disparities in pay between specialties. So I did 5 years of residency, 3 years of pediatrics, 2 years of pediatric emergency, and then an additional research year on top of that. And I make a third of what my partner makes, who is a radiation oncologist who did a 5 year residency and then a 1 year fellowship. And his work is during the daytime, like 9 a.m. to 4 p.m., Monday through Thursday. He works like 2 weekends a year. So despite the like higher acuity of my lifestyle and the work, just the nature of pediatrics is that it's, undercompensated compared to other specialties. So I think that does factor in. That being said, as much as the disparities I think are unfair, like there's no physicians in Canada who are starving. I think it's pretty easy to make a decent living. And then in terms of your other questions beyond lifestyle, what were the other two?
I was wondering about if there's a physician shortage, and if so, like, are there any strategies that Canada is currently taking to mitigate that?
Yeah, excellent question. So we definitely do have a physician shortage. I think it's not only in the number of physicians, but it's also the distribution of physicians. So a part of the distribution geographically, we have more people concentrated in urban areas, fewer out in rural areas. We are really lacking people who are doing longitudinal family medicine. About 50% of medical students will do a family medicine residency, but then afterwards, not many of them are choosing to do longitudinal family medicine clinics because of the challenges that I've mentioned. It's a really hard job the way it's structured right now. So many of them are deciding to do work in other aspects of the healthcare system, maybe in the emergency department, maybe anesthesia assisting, surgical assisting, virtual care. There's so many different ways that you can work as a family doctor. And I think a lot of people are choosing these other roles because there is more support. You're not by yourself. You're not trying to run a small business in impossible circumstances. So that I think is our major issue right now, our geographic maldistribution and lack of good distribution amongst specialties, especially amongst family medicine and people doing longitudinal family medicine. In terms of areas and ways to fix it, there's some provinces that are experimenting with new ways to pay family doctors. British Columbia recently piloted a program where I think they make a little bit more money and it's a pretty decent package. There's a program called Our Care. If you Google like OURCARE care.ca, this is led by a doctor, family doctor, Tara Kieran from Toronto, who is really looking at like evidence-based ways to improve family medicine and creating family health teams so that if you're a family doc, you're not kind of working by yourself in a silo, but you have access to like a nurse practitioner, social worker, all these different professions that I have the benefit of working with at the hospital. So she's working hard to advocate for that. And Dr. Jane Philpott, who was a family doctor in the Toronto area and then was our former health minister years ago, is now working with the Ontario government to try and work on team-based care in family medicine in Ontario. So I think that that will go a long way to fixing our health system issues. In terms of other ways to actually increase the number of doctors, they're looking at streamlining it and fast tracking the credentialing for internationally trained doctors. Right now, a lot of people have to redo residency, which is quite a barrier in and of itself. And even applying for residency, there's not many spots. That is one area where we really differ from the States. Our ratio of medical students to residency positions is really tight. There's barely space for the medical students who have trained in Canada, let alone folks who came internationally and want to retrain and work here. So I think that's an initiative that they're building on. They're building new medical schools, which is a good start, but I think a little bit limited because we're so resource limited in terms of our human resources right now that it's hard to create a new medical school because who's going to train and teach these new medical students, right? So I've been seeing a lot of movement toward like, oh, let's just train more medical students without people realizing, although that looks politically popular, it's still really challenging because we already have few people. So we are doing our best. And I think there's also an ethical question too about how much we should recruit physicians from other countries. I don't think it's necessarily a bad thing if people want to move here. You know, we're all for international mobility. But at some point, if we're recruiting very hard from other countries, it almost feels like we're poaching and on a global scale, like robbing Peter to pay Paul. Other countries have needs for physicians just as much as Canada does. So I'm not sure if that's like a sustainable long-term solution for our country, but it's something that does come up a fair bit. Great question. Sorry for the monologue speech, but I hope that it gives some insights.
No, that was great. Thank you.
Perfect. I've got 10:05 Eastern time. Any other questions? I'm happy to stick around for longer as well too. And I don't think I said anything unhinged. Well, maybe we'll see after this last question, but I was going to say you can put it up on YouTube if you'd like. Mackenzie?
Hi, you mentioned that a lot or most of the hospitals are private, and I was wondering if there's any kind of movement to make them more public or if people are kind of happy with them being privately nonprofit owned.
Oh, this is a great question. So in my province, Ontario, most of the hospitals are private nonprofit, but in other provinces, I think the majority of other provinces, they are actually public hospitals and government owned and operated. So that is a bit of a distinction. I don't think that people really know or care whether or not the hospitals are like government owned and operated or private nonprofit institutions. I think what we are very concerned about and what we are seeing a bit of a move towards is private for-profit institutions, especially if they're investor owned. So that essentially means that you're creating an environment where the physicians and healthcare providers are beholden to shareholders. And just by the very nature of that kind of work, it takes away from, I think, the focus on the patients and wanting to make profits. And we've seen in areas of our healthcare system that have focused on this, long-term care being one of our examples, that when you do have for-profit ownership, there tends to be lower staff to patient ratios. There can be higher risk of complications. We saw worse outbreaks of COVID-19 in long-term care facilities that were for-profit owned compared to those that were nonprofit or municipally owned. So that is an area, it's not common, and there's no, I think, like major hospitals that are private for profit. A lot of it is like smaller standalone surgery clinics, like a clinic that does, let's say, like cataract surgeries or hernia repairs. So they have a very narrow focus. I don't think that we've fully explored or realized the impact of these places yet in Canada. We kind of have to extrapolate from other countries and from other areas of the healthcare system. But I think it is an area that many of us are concerned about. And we're also seeing more creeping of private equity into our healthcare system, which I know has been an issue in the United States previously. So we're trying to monitor that and learn more about the issue and seeing how we can quell private equity, because a lot of private equity will buy a bunch of practices, try to make a quick profit off of them with the goal to then sell them to make more of a profit. But if you're selling or closing practices, it doesn't really lead to like long-term sustainable healthcare access. So we're trying to limit that corporate influence in healthcare, but as I'm sure you guys can relate to, that can be a bit of an uphill battle.
And then Dr. Bechard, I know you offered to stay longer, and we have on our schedule that you're available until 10:25 or 7:25 your time.
Yeah.
Is that your understanding or
Yeah, that's my understanding
okay,
too. Just I talk fast. I like to leave lots of time for
okay.
questions. And from my experience, I've learned that people are usually never upset if you end early and they get a little bit of extra time in their day. So that's why. And I find the questions and discussion are the biggest part of this. But if anyone, because we've had a few questions, if anyone does need to get up and take a break, I won't judge, but I'm happy to stay around right until 10:25. Thanks for clarifying, Zachary.
Yep. Just wanted to make sure we weren't keeping you from something.
No, no, no. Here, I'll close this so we can see each other better, but if anybody has questions about specific slides, I can bring it up. Is it Anana?
Yeah, thank you. I wanted to ask how healthcare in Canada or the system in Canada kind of addresses healthcare disparities among like Indigenous peoples or other marginalized groups, and how like you ensure um equitable access to care in rural and, remote communities.
Oh, this is an excellent question. I think overall, we could definitely be doing a better job in terms of equitable healthcare access, both by geography, by race, ethnicity. I do think that one of the strengths of our system is because it is publicly funded, it is more accessible, right? People of any income can access it. That does make it a little bit easier. But does that completely fix issues of systemic racism and bias amongst healthcare providers and amongst the system itself? Absolutely not, right? So we've, I think, fixed some access issues. I do think that there's growing awareness towards it. And I think all medical schools right now do include some training in the social determinants of health and systemic bias. And especially with our history of colonization of Indigenous peoples in Canada, the most stark disparities in healthcare discrepancies that we see are often between like the Indigenous and settler populations because of that history and frankly present of like colonization and racism. Um, I do think that there is a lot of willingness amongst healthcare providers to learn. Obviously, I can't speak for anyone, but at least amongst my colleagues, um, we we do our best to undergo a great degree of training in terms of cultural sensitivity. That's a key part of medical programs. In our emergency department in particular, we've implemented health equity rounds. So we have like morbidity and mortality rounds where if a patient has a bad outcome or if things don't go as well as they could have, we kind of look into the reasons for that. We also have awesome and amazing rounds where when things do go well, we look into what contributed to that. And then our health equity rounds are very focused on situations where we feel like, the patient's intersectional characteristics might have implemented or might have affected their care, their outcomes. So as an example, I won't get into too many details, but there was a patient who came into our hospital who was a victim of a hate crime. And we kind of spoke a little bit about, the work that we did and how we supported the patient and ongoing support, and also like increasing provider awareness of different resources so that if patients do come in because they're victims of hate crime, that we know that we're giving them like the maximal support that we can. So I'd say on like a micro level, people are working very hard to get better at it. In terms of more systemic issues and programs, yeah, we're working into our training, but I wish that we could like fix systemic racism and culture really rapidly, but I think it's something that takes some time. In terms of like the geographic disparities in care and getting access to care in those rural and remote regions, there's been so many efforts there. They created a whole medical school in my province called the Northern Ontario School of Medicine because they realized that taking like urban medical students and then trying to entice them to practice in rural areas tends to not be as effective as trying to do targeted recruitment for people who are already from rural areas who want to go into medicine and then training them. And then they're much more likely to go back and serve some of those communities because they have roots there. So that has been a really good initiative. There's loan forgiveness programs for physicians who practice in rural and remote areas. We're trying to look into a national licensure program right now too, because our healthcare system has those different silos. You're only licensed to practice in one specific province or territory. But let's say I have a friend in Saskatchewan, it's a relatively small province, well, large geographically, but small population. If they are in a subspecialty and they need urgent coverage and they can only ask for other physicians in Saskatchewan to cover them, that's a really small pool to choose from. So an area of advocacy that many physician groups have been doing has been to look at national licensure. So that way you're not like you're licensed to practice anywhere in Canada. So that way if I'm an ENT surgeon and my colleague in Saskatchewan needs urgent coverage, I can actually go practice there. Because right now there is a very thorough application process that is very time consuming, very resource financial consuming. So a lot of rural physicians have been really pushing for this national licensure. but it's still an issue. We're seeing, unfortunately, a lot of rural emergency departments closing over the summer because they have trouble staffing them, with physicians and especially nurses being away or being unable to work there. The burnout is really high. And then when those departments close, the patients then go to the next community emergency departments, which are getting more overburdened. So it really creates a bit of a domino effect. So we really need to, I think, fund our healthcare system better. We've had a history of various governments, I think, across all provinces and federally that have not provided it with the proper funding, and now we're seeing, I think, some of the effects of that. But great questions. Ariana?
Hi, yeah, I thought of this question actually. It was prompted by Anana's question a little bit, but because like Canada has such a great like publicly funded healthcare system, how does like Canadian sorry, I'm trying to word this question correctly. Like I'm just wondering how like Canadian politics like influences healthcare because like we're seeing in the US like with the current administration and like just the way that the parties have gone, there's a lot of say on healthcare issues like vaccines and like reproductive care. So I'm just kind of wondering what that's or if there's anything like that in Canada.
Yeah, absolutely. I think healthcare is still very politicized here in Canada. Um, it, I think that any party suggesting that we should completely get rid of Medicare would really have an uphill battle. I do think that there are individuals, and I truthfully don't know if it's intentional or if they just are ignorant about the effects, who do advocate for two-tiered healthcare. And the reason is that they'll look at other countries. They'll say, "Oh, look at the UK. Look at Australia. Some of their wait times are lower than ours. They have a two-tiered system. We should adopt that two-tiered system." And I get the logic, but the issue is that when we look at how the systems are different, there's a lot of variables other than them being two-tiered. So if we look at like the National Health Service in the UK in particular, they devote a much higher proportion of their healthcare spending is from government sources. So essentially, the government is putting more money into the healthcare system. Same thing with Australia. And when we look at a lot of the wait times for countries that have moved to two-tier, it's really interesting. If the wait time was here beforehand for people who have money and people who don't have money, they're about here. And then when you move to two-tier, the wait time is lower for those who have money, but goes up for people who don't have money. So the average is about the same. So we try to do a lot of myth busting at Canadian Doctors for Medicare, to say, look, like having a two-tiered system rearranges a wait list, but it doesn't necessarily shorten the wait list because at the end of the day, the bottleneck is seeing enough healthcare providers. So let's maybe talk about getting more healthcare providers in our system. More importantly, being more efficient with how we do healthcare. There's so many things that are really, frankly, dumb in our system right now. We're trying to implement centralized referrals is one thing. For example, right now, if I see a child in the Emerge, I say Emerge for emergency department. I realized during my master's degree that not everyone says that in the US, and they're like, what is an Emerge? In the emergency department, ED, ER, whatever you want to call it. If I see them and they have anaphylaxis and I refer them to an allergist, I just refer them to like one of the allergists I know that I've referred to before who seems to have done a good job. I don't know if there's another allergist down the street that opened a new practice. I don't know if their wait times are shorter. We have no central organization for stuff like this, and it really increases our wait time. So we're trying to get across like, hey, like rather than just saying, oh, let's start asking people to pay for care and that will fix our system. Let's look into like real solutions that'll make it better. We still have like a lot of, I think, political lines drawn around different healthcare facets like vaccinations. We do see that there's people who are increasingly mistrusting of the healthcare system. And I think part of that is rooted in very valid reasons. I think medicine on both sides of the border has a horrible history of being like very biased and very patriarchal and racist. So I get where some of the distrust comes from. But then definitely I do think that there's some policymakers or politicians who will recognize that distrust and really play upon it and use that fear to like sow support for their side. So unfortunately, I think we do see that here. I don't think we have maybe as many extreme examples yet, but definitely those sentiments are there, and I think they're growing too. Yeah, good question. I think I was I think you could still post it on YouTube. I don't think I called out anyone too viciously. I should mention as well too, Canadian Doctors for Medicare is truly like a nonpartisan organization. We will meet with anyone who is willing to talk to us. Oftentimes our values can sometimes align with certain parties more than others. We've had an easier time, but I do think that we have met with policymakers from all the various political parties in Canada, and we're always trying to grow that base and um, trying to not just be in our echo chamber. So we do try to reach out across political aisles.
I guess to end this off, I kind of have a fun question. I'm sure you see how much the US spends per capita on healthcare, and obviously we have our own problems. Have you ever fantasized about what the Canadian health system could do with the amount of money the US spends? And if you had our budget for a day, per capita spending for Canadians, what you would increase access to?
Oh, that's a fun question. That's such a good question. I think, oh, now my worry is that even if we were to spend a lot on healthcare, that we wouldn't spend it appropriately. But I think areas that are high value, again, that ounce of prevention worth a pound of cure is so key. So I think fixing our primary care system is so important. I think reducing the disparities between what family doctors make versus other specialists is such a key thing. Now, I'm, you know, don't feel bad for me. I live a great life, but compared to other specialties, I'm one of the most underpaid subspecialties being in pediatric emergency medicine. But I would take a pay cut if family doctors would get more because my job becomes so much easier when patients have family physicians. Like I have so many patients who come in with no family doctor, or they'll recognize like this isn't an emergency, but my family doctor is away on medical leave for 3 months and there's nobody to cover for them, so I had to come see you. I'll have to like manage a lot of referrals. There's patients that I saw 3 months ago in the emergency department where I'm getting like ultrasound reports back and I'm managing them just all on my own time, right? Because you can't do it on an emergency shift because it's too busy. So it just becomes like a hobby that you don't really feel good about doing because it's not exactly a great way to do care. So I would immediately pay family doctors more. I'd allow family doctors to have more flexibility in how they want to be paid. If they want to be salaried with like benefits and pension, absolutely, let's offer that because right now a lot of them are working in like a small business model. Let's make sure that there's group practices. Let's make sure that every family medicine practice has a dietitian, a psychologist, or social worker, somebody who can do mental health counseling. Let's make sure that there's nurse practitioners who can maybe help with some of the chronic patients and patient education around diabetes, et cetera. Like, let's just build that in for every family doctor. And also, let's adopt the model of family medicine that's practiced in Denmark and many other regions of the world, where it's kind of like the school board model. So that way, when you move to an area, you're automatically registered with a family doctor. Right now, it's a little bit like the Hunger Games for people applying for and fighting to try and find family doctors with practices that are open. One of my friends yesterday like shared on her Instagram story, like, look, there's a family doctor downtown who's accepting new patients. Everybody run for it. And it really is like that right now. So if we're able to take off that burden, I think that would have ripple effects in a good way down the system. Yeah. And like fancy treatments, robot surgeries, all that is important and key and good to have. But if people can't access that stuff because they can't get a referral because they don't have a family doctor, it's not going to really help you. So I think it's the basics. And obviously public health funding too is really crucial and key as we saw during the pandemic. And I think I understand why many of us have amnesia for that period. But I think that unfortunately our public health funding has amnesia for that period, and we should really be, I think, recognizing now how important public health funding is.
All right. That's interesting to hear as well because there is a lack of emphasis on primary care in the United States, to a certain extent as well. So maybe y'all can figure it out and then we'll copy you.
I wish we'll try, we'll do our best. But no, I will say like, not to say that there's nothing great about the state system. I think like there's so much innovation coming out of the United States healthcare. I think the research funding and the research being done in the States is absolutely amazing. I know that there's, with the current environment, some challenges being imposed upon that. But I do think that like other countries around the world benefit from a lot of the innovation that happens in the country. So I don't want to make it sound like I'm like some smug Canadian saying my system's great. Like I think that probably sometimes people are too hard on American healthcare, but obviously there's real problems both sides of the border, and I think we have a bit to learn from each other. But yeah, you guys got to get that universal healthcare thing sorted. This group here will make it happen.
Maybe one of us will do it and get voted the greatest American.
Exactly, exactly. Future Tommy Douglas of America.
All right. Well, thank you again, Dr. Bechard, for spending your morning with us. 6 a.m. is never easy, maybe for you with shift work, but we are very appreciative of your time.
Thank you so much. And if anyone has questions that come up afterwards, or even just reactions or things you want to share, again, I can stick around here for another 5 minutes if you want to talk one-on-one. But Marvin also has my email, so we can get in touch that way.
Dr. Bechard,
Yes, hi, Betty.
I finally figured out how to unmute myself. It wasn't easy.
Congratulations.
But folks could leave, and you may have already answered this while I was busy with my errand there. But I have heard, I think one of your Canadian speakers have shared that like more than 95% of Canadian doctors are are not employees of anybody, that they are either in private practice or they are consulting, they're paid by the government after they send a bill to the government, or that they belong to a group practice. And you were just talking about being okay with family doctors getting salaried and getting the benefits and everything. Can you tell me how many, right? Is it still less than 5% of all doctors who are licensed and practicing are employed? And so for instance, are you a contractor or are you employed?
I'm an independent contractor. I'm not employed. Even though I get a salary, I have no pension, no benefits. I have to like pay for the benefits
Oh,
myself. So, and I think that this is a relic of when physicians were railing against the introduction of Medicare. They're like, fine, you could publicly finance it, but we still want to be privately delivered. We want to maintain our autonomy. And I do think that it's a bit of a generational shift now that we have many physicians who have families, who are no longer the sole provider, more who are women, and I think men who are like younger are participating more in that family environment. I think we're seeing less of the traditional roles where it used to be like, you know, to be blunt, like a male doctor working who had a stay-at-home partner who would take care of all the family stuff. I think now we're in a world where people are more open to having the security of salary, benefits, pension. This is a very generational thing. We did a survey back in 2018 and found that the majority of residents was about 50-50, but just over half would be happy to give up some of their like autonomy that way for like the security of salary and benefits and more of an employee model. So there's not a large push for it. It's definitely not every physician in Canada who wants to move to something like that, but I think that there's more openness to it than in prior years. But you're totally right. Right now, the vast majority of us are independent contractors, which is great because in theory you have more freedom over your work, but also you don't get a lot of the benefits of employees and some of that security. And functionally, I have to like, you know, I can't decide when I want to work. Like I'm scheduled for a shift at noon today. I got to go in and do that shift. So I kind of have like the bad parts of being an employee without the benefits of it.